On today's show, we're discussing testosterone therapy and how proposed changes to drug labels could reshape how it's prescribed for men in the U.S. This is the JAMA Medical News Podcast. I'm News Director Jennifer Abbasi. Associate Managing Editor Kate Schweitzer is here to talk about her story. Kate, thanks for joining.
Thanks, Jen.
First, tell us what's changing.
So in June, the U.S. Department of Health and Human Services proposed revising the prescribing information for testosterone therapy. The proposal includes three major label changes. First, HHS wants to remove a longstanding statement that the safety and effectiveness of testosterone therapy hasn't been established for men with age-related hypogonadism or low testosterone that develops with aging. Second, it wants to narrow a warning about prostate cancer so that it applies only to men with metastatic disease while continuing to recommend appropriate screening and monitoring. And third, it wants to update warnings about enlarged prostate or benign prostatic hyperplasia to reflect evidence that testosterone generally doesn't worsen symptoms. Supporters say these changes simply bring the labels in line with newer evidence, but critics argue they could unintentionally expand testosterone use well beyond the patients who need it. That's significant considering we've been here before. During the low T boom of the early 2000s, aggressive marketing campaigns portrayed testosterone replacement as an anti-aging cure-all. Prescriptions soared, dedicated low T clinics opened across the country, and many men were prescribed treatment without clear evidence of testosterone deficiency. That prompted the FDA to issue warnings in 2015 and require a large safety study.
Okay, and that newer research, is that what's driving this conversation now?
Yes, the Traverse trial enrolled more than 5,200 middle-aged and older men with symptoms of hypogonadism who either had cardiovascular disease or were at high cardiovascular risk. The main finding was reassuring. Testosterone therapy did not increase the risk of major cardiovascular events like heart attack or stroke. Along with other studies, including the federally funded testosterone trials, Traverse became the foundation for HHS's labeling change recommendations. But the interpretation of those results is where experts disagree. I spoke to a principal investigator of Traverse who cautioned against overgeneralizing the findings. He pointed out that the trial also detected increases in atrial fibrillation, pulmonary embolism, and fractures, and there were several limitations to the study. Participants were followed for less than 3 years, men at elevated prostate cancer risk were excluded, and only one testosterone product, a gel, was studied. So while many experts agree the trial improved our understanding of testosterone's cardiovascular safety, not everyone believes it justifies broader prescribing.
Okay, so then who actually should receive testosterone therapy?
That's not straightforward either. There's not a single definition of what constitutes true hypogonadism. The American Urological Association uses a different testosterone threshold than the Endocrine Society, and some clinicians use even stricter criteria in their own practices. Historically, testosterone therapy has been approved primarily for men with what's called classic hypogonadism, usually caused by generic conditions or injury to the testes or pituitary gland. That's relatively rare. Supporters of the label changes argue there are many other men with consistently low testosterone levels and symptoms who could benefit. But critics counter that testosterone naturally declines with age and can also fall because of chronic illness like obesity. They worry that expanding access could blur the line between treating a medical condition and treating normal aging. One endocrinologist told me that hypogonadism absolutely deserves treatment when it's appropriately diagnosed, but emphasized that careful patient selection remains essential.
So even among experts who support testosterone therapy, it sounds like there are still important caveats.
Exactly. No one I interviewed supports giving testosterone based on symptoms alone. They emphasize the importance of confirming low testosterone with repeated blood tests, carefully evaluating patients for other possible causes of their symptoms, and continuing to monitor men after treatment begins.
So what now?
The proposed label changes aren't final. Drug manufacturers still have to submit updated labeling to the FDA, which will decide whether to approve the revisions. Regardless of what happens, important questions remain about long-term safety, who benefits most, and how to prevent a repeat of the widespread overprescribing seen during the low T era.
Thanks, Kate. All right, if you'd like to learn more, we'll include a link to Kate's story in the show description. This week, we also published a piece examining a new study that adds to existing evidence that acetaminophen use during pregnancy does not appear to cause autism. You can find that and all of our stories at JAMAmedicalnews.com. Thanks to Kate Schweitzer for joining me. I'm Jennifer Abbasi for JAMA Medical News. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening and join us again next week.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.